Thank you, Dr. Atik, for this wonderful opportunity of presenting in your IC. So my talk will be on aberrometers. Aberrations are the imperfections of the eye that results in inability of the light to focus onto the retina, effectively causing a defect in the visual system. So basically, the optical aberrations are the major cause of poor vision. So especially when a patient walks in with 6/6 and not happy, most of the time this would be the reason for it. So it occurs when the light from one point after transmission through the optical system does not converge to or diverge from a single point. Any deviation of the optical system from a paraxial optics results in the aberrations. So the measurement of this is called the aberrometry. So this is a bit of a physics which says that the light rays and wavefronts are two mutually complementary approaches to the light propagation. Wavefronts are always normal, that is perpendicular to the light rays. The parallel beam of light produces a planar wavefront, whereas a converging beam produces a spherical wavefront. For a light to converge to a perfect point, the wavefront emerging from the optical system must be a perfect sphere centered on the image point. If that doesn't happen, that's called an wavefront aberration. So an aberrometry is a measurement of imperfections in the optical system, and the first ever clinically available aberrometer was a COAS by AMO. So basically, how do we analyze these aberrations? There are certain measurement metrics which can be done at the level of the pupil or at the level of the retina. When it comes to the pupillary level, it's called the Taylor series expansion, Fourier analysis, and the most commonly used Zernike polynomials. And at the level of the retina, it would be the point spread function, Stirls ratio, modular transfer function, phase transfer function, and the optical transfer function. So this is a Zernike polynomial. The shape of the wavefront can be analyzed by expanding it into these sets of the polynomials. So wherein the first two orders, the 0 and the first would be a constant, the second would be the lower order, and everything after this would be the higher order aberrations. So the unit for wavefront aberration is microns or fraction of wavelength and is expressed as the root mean square RMS values. The higher the RMS value, the greater is the overall aberration for a given eye. Majority of patients have a total RMS value less than 0.3 micron for a 6 mm pupil. The pupil size is also very important when the calculation occurs. The most higher order Zernike coefficient have a mean value that is very closer to the 0. The most important Zernike coefficient affecting the visual quality would be the defocus, spherical aberration, coma, and the secondary astigmatism. The polynomials, as I said, the first order, second order, and all, it can be expanded to any arbitrary order if a sufficient number of measurements are made for the calculation. Currently, that's the biggest drawback for us because we could do only till the 7 orders. The spectacles can correct for only the second order aberration. That's very important clinically. So as I said, this is at the level of the retina. Again, same like the Zerlicke polynomial. Okay, so type of aberrometry could be subjective or objective. Subjective is almost like absolute nowadays. It's only the objective that we are using. It has an outgoing, ingoing, and ingoing feedback. The outgoing works, I mean, like the aberrometers that work on the outgoing phenomenon is the Hartmann-Shack and the wavefront sensor. Ingoing is the Sherring's aberroscope, cross-cylinder aberroscope, and the ray tracing technique. Ingoing feedback is a spatially resolved refractometer. Shack-Hartmann devices evaluate the light bounce back from the eye. That's why it's called an outgoing reflection. There are numerous lenslets focused on the reflected wavefront. If there are no optical aberration in the system, an uniform pattern of perfectly spaced dots will be seen. And if it is not, then it says the amount of aberrations. The ladder wave, Xi wave, VASCA, wavescan all works under this principle. Sharing and ray tracing aberrometry, the retinal image formed is imaged and then evaluated by a charge coupled device sensor that determine the deviation of spot from the ideal. So you have an ideal spot and there is a reflected spot that has been compared. This is the technology that's been used in the wavelight and the Schwind aberrometers. Schlitz IOScope is a double pass aberrometry. Basically, an infrared light scans the retina and the reflected light is measured to create a wavefront. So basically, we are doing two measurements. So that's why it's called a double pass aberrometry. The NIDAC OPD scan works on this principle. The total disadvantages of all these aberrometers are that it measures all the points at once. So there is a lot of data confusion. There could be a compromised resolution. It's a limited dynamic range, so cannot measure highly irregular eyes, and it is highly sensitive to noise. Coming particularly to the Hartmann, it measures the reverse aberration, so it is considered to be non-physiological. Sherrings need a 2D imaging of the retina. A 3D image which has been converted to 2D image can lead to a lot of additional noise and errors. Shioscopy does not measure the skew deviation, so inaccurate trefoil, quadrifoil. There's no open field fixation, so an instrument myopia can be induced in the younger adults. the aberrometers that is commercially available and that stood the test of time are the NIDA OPT scan, COAS, iTracy, Maxwell, and the Aura. We'll skip the NIDA and we'll move on to the iTracy, which is, that's a one aberrometer which is commercially available. I have no financial interest. So there are multiple parameters that could be checked with this. Basically, iTrace works well for a cataract surgery. It helps us to find the origin of aberration in an eye. It increases the premium lens success, helps in planning the toric IOL. It identifies the cause of post-operative dissatisfaction for the patient. Right. So the aberrations, the wavefront verification with the help of RSD and the wavefront values allows rapid diagnosis of both the lower order and the higher order aberration in a patient. The iTracy has got a unique feature to separate the corneal and the lenticular astigmatism. So you have the whole eye's aberration and you have the corneal aberration. When you subtract the corneal aberration from the whole eye, it says whether the internal aberration is higher or not. So the origin of aberration, whether it is from the cornea or the internal, could be identified and treated accordingly. So this is an early cataract changes. Sometimes the patient will have 6/6 vision but may not be very comfortable with the vision. Once you do it through an iTracy, it will tell the actual patient's aberration, and even if the patient has got a 6/6 vision, if the quality of vision is not good, we are justified in doing a cataract surgery for this patient. And it helps in assessing the angle kappa. We know that high angle kappa is a contraindication for implantation of premium IOLs. Choosing the right IOL, the iTracy, the aberrometers, most of the aberrometers, it gives the value of the spherical equivalent value of the patient, the corneal asphericity, the angle kappa. So with this, you can actually tailor make your IOLs and customize it for every patient. Toric oil planning, it gives a complete planning output, and in case if the patient is not happy with the toric oil outcome, it will give the amount of rotation that is required also. For a dissatisfied patient, this is one visual function analysis which is very good because it gives a Snellen E simulation analysis, which can actually give you an idea about the potential visual complaints of what the patient is telling to you. You can assess the contrast sensitivity, as I said, like post-op assessment of IOL tint and centration. And the most important thing is the intraoperative aberrometry, and which is the advanced innovation that's happening now, which can be attached to any of the microscopes. It can actually do measurement both in the pseudophakic and the aphakic measurement. Using the aphakic measurement as a primary data point, the device provides guidance on IOL power selection after your surgery is over, especially in a post-refractive surgery eyes. Intraoperatively, you can refine the IOL power and then implant so that the IOL power is perfectly calculated for the patient, and also for the orientation of the toric IOLs when it comes to a post-refractive surgery eye. And this is Halos is the most advanced one. The advantage is that it monitors and confirms accuracy throughout the procedure. It's a real-time imaging of the eye. So in spite of the widespread use, the application of wavefront technology is still at an early stage. It's mostly a theoretical one now. In the future, this technology has enormous potential to alter our way of thinking about the visual function, refractive error, and their corrections also. Thank you.